Good afternoon. So today we'll be discussing about the endocrinology topic. And in endocrinology, we'll be discussing first about the thyroid gland. Thyroid maintain an increase in the basal metabolic rate by means of iodine containing thyroid hormones, that is T3 and T4, through upregulation of carbohydrate and lipid catabolism and stimulation of protein synthesis in a wide range of cells. So, thyroid maintains an increase in the basal metabolic rate by means of iodine containing thyroid hormones T3 and T4. One of the most important function of thyroid hormone is its critical role in brain development in the fetus and neonate. So that's why if the mother is hypothyroid, so there are chances of the child may they may have delayed milestones. So the thyroid supplementation is very important during pregnancy if the mother is a hypothyroid. The function of thyroid gland can be inhibited by a variety of chemical agents, collectively referred to as goitrogens. Thyroid gland follicles also contain a population of parafollicular cells or C cells which synthesize and secrete the hormone calcitonin. Calcitonin promotes the absorption of calcium by skeletal system and inhibits the resorption of bone by osteoclast. So this is the normal metabolism right from thyroid gland to the brain, the pituitary, the thyroid releasing hormone. So because of that, the thyroid stimulating hormone. So on the thyroid gland, there is TSH receptor. So with the help of a G protein, so again in a reversible way, there is secretion release of T3 and T4 hormones. So coming to the diseases of thyroid, the conditions associated with are hyperthyroidism, that is excess release of thyroid hormones, hypothyroidism, deficiency of thyroid hormones, and mass lesions of thyroid. First, hyperthyroidism, that is hypermetabolic state caused by elevated circulating levels of free T3 and T4. The hyperthyroidism, it is caused by the elevated circulating levels of free T3 and T4. So what are the diseases or disorders associated with thyrotoxicosis? First, primary and secondary. Primary, it causes diffuse toxic hyperplasia or Graves' disease, hyperfunctioning, that is toxic multinodular goiter, hyperfunctioning adenoma, iodine-induced hyperthyroidism, okay, and neonatal thyrotoxicosis associated with maternal Graves' disease. And secondary, that is the TSH secreting pituitary adenomas, that is a granulomatous thyroiditis, subacute lymphocytic thyroiditis, tumor ovary, and fasciating thyrotoxicosis. The clinical manifestations of thyrotoxicosis include changes referable to the hypermetabolic state induced by excess thyroid hormone. Second is the overactivity of the sympathetic nervous system, that is an increase in the beta adrenergic tone. Third is the constitutional symptoms like skin, it is soft, warm, and flushed. Heat intolerance, the patient will be having heat intolerance and excessive sweating. Weight loss, despite of increased appetite due to increased sympathetic activity and hypermetabolism. GI symptoms include stimulation of hypermobility, malabsorption, and diarrhea. Cardiac manifestations include palpitations, tachycardia, cardiomegaly, arrhythmias, congestive heart failure in elderly patients due to aggravation of pre-existing heart disease, and hyperthyroid cardiomyopathy. Neuromuscular, that is the overactivity is of the sympathetic nervous system produces nervousness, tremors, or hyperactivity, emotional liability, anxiety, and inability to concentrate, and insomnia. Thyroid myopathy, it includes proximal muscle weakness and decreased muscle mass. Ocular manifestations, that is a wide staring gaze and lid lag, are present because of sympathetic overstimulation of the levator palpebrae superioris. True thyroid ophthalmopathy associated with proptosis in Graves' disease. So this is a photograph showing hyperthyroidism. Okay, a wide staring gaze by overactivity of the sympathetic nervous system. We see in Graves' disease. And in skeletal system, we see osteoporosis, that is increased risk of fractures due to bone resorption, increasing porosity of cortical bone, and reducing volume of trabecular bone, skeletal muscle atrophy, thyroid storm, that is an abrupt onset of severe hyperthyroidism due to acute elevation of catecholamine levels, most commonly in patients with underlying Graves' disease during stress, infections, surgery, or cessation of antithyroid medications. In a medical emergency, and untreated patients die of cardiac arrhythmias. And next entity called as apathetic hyperthyroidism, thyrotoxicosis occurring in elderly, especially in the unexplained weight loss and worsening cardiovascular disease. So, how can we diagnose these conditions? Diagnosis, that is serum thyroid stimulating hormone levels and free T3 T4 by they are decreased. T3 T4 levels and TSH are decreased even at the earliest stages. In secondary hyperthyroidism, the TSH levels are either normal or raised, and radioactive iodine uptake by thyroid gland etiology, example in Graves' disease, okay, the diffusely increased uptake in the whole gland, toxic adenomas, and thyroiditis. Therapeutic options include beta blockers, thionides, iodine solutions, other agents, and radioiodine. Coming to the next entity, that is a hypothyroidism, the caused by any structural or functional derangement that interferes with the production of adequate levels of thyroid hormones. But again, it includes primary hypothyroidism and secondary hypothyroidism. Primary hypothyroidism includes developmental abnormalities or thyroid hormone resistance syndromes, post-ablatives, autoimmune hypothyroidism, especially in Hashimoto's conditions, drugs like lithium iodides. Secondary hypothyroidism includes pituitary failure or hypothalamic failure. Coming to the primary hypothyroidism, it includes congenital, acquired, and autoimmune. Congenital hypothyroidism is a result of endemic iodine deficiency in the diet. Other forms include inborn errors of thyroid metabolism, that is disharmogenic hormonogenic goiter, Pended syndrome, that is hypothyroidism, with sensory neural deafness, thyroid agenesis, that is complete absence of thyroid parenchyma, thyroid hypoplasia, the gland may be reduced in size, and thyroid hormone resistance syndrome. Acquired hypothyroidism caused by surgical or radiation induced thyroid parenchyma, that is total thyroidectomy, any exposure to radiation, that is radioiodine treatment of hyperthyroidism. Drugs like methimazole, propylthiouracil, lithium, and autoimmune hypothyroidism, mainly it includes the Hashimoto's thyroiditis. Secondary hypothyroidism is caused by a deficiency of TSH and TRH. Hypopituitarism, that is the pituitary tumors, and postmortem pituitary necrosis, trauma, and non-pituitary tumors, hypothalamic damage from tumors, trauma, or radiation therapy. Classic clinical manifestations of hypothyroidism include cretinism and myxedema. Cretinism refers to hypothyroidism developing in infancy or early childhood. Cretin is derived from French cretin, meaning Christian or Christ-like, so mentally retarded as to be capable of sinning. Formerly common in areas where iodine deficiency is endemic include Himalayas, China and Africa and other mountain areas. May also result from inborn errors of metabolism that interferes with biosynthesis of hormonal levels of thyroid hormone. It is called as sporadic cretinism. Clinical features include impaired development of skeletal system and CNS, manifested by severe mental retardation, short stature, coarse or facial features, protruding tongue, umbilical hernia, mixed edema or gull disease, that is hypothyroidism developing in older children and adults. Manifestations includes generalized apathy and mental sluggishness. Individuals are listless, cold intolerant, often obese. Mucopolysaccharide rich edema accumulates in skin. Pericardial effusion is common. Cardiomegaly and heart failure is present. So coming to the laboratory evaluation of mixed edema, it includes serum TSH levels. They increase in primary hypothyroidism, not increased in hypothyroidism caused by primary hypothalamic or pituitary disease, and serum T4 is decreased. Thyroiditis, that is inflammation of the thyroid gland, is CVC in conditions like infectious thyroiditis, Hashimoto's thyroiditis, subacute granulomatous thyroiditis, subacute lymphocytic thyroiditis, Riedl's thyroiditis, and palpation thyroiditis. So coming to the Hashimoto's thyroiditis, it is characterized by gradual thyroid failure because of autoimmune destruction of the thyroid gland, most relevant in age group of 45 to 65 years, and females are more prone, and also causes non-endemic goiter in children. There is diffuse enlargement of the thyroid gland. Pathogenesis, it is autoimmune disease with progressive depletion of thyroid epithelial cells and gradually replacement by mononuclear cell infiltration and fibrosis. The effector mechanism of thyrocyte death include possible reaction of CD4 plus T cells to thyroid antigens, producing cytokines interferons, promoting inflammation and activate macrophages. CD8 plus cytotoxic T cell mediated cell death. So the genetic component occurs increasingly in first degree relatives and unaffected family members having circulating thyroid autoantibodies, and it is associated with HLA DR3 and DR5. So this is the picture showing the pathogenesis of Hashimoto's thyroiditis. Right on the thyroid epithelium, there is breakdown of peripheral tolerance to thyroid autoantigens, resulting in progressive autoimmune destruction of thyrocytes. Morphology, the thyroid gland grossly, it is diffuse, there is diffuse and symmetrical enlargement, intact capsule and well demarcation of gland from adjacent structure. Cut section is pale, gray tan, firm and somewhat friable. Microscopy. So cut section grossly, you will see it looks like that of a lymph node architecture. That's what is also called as stroma lymphomatism. Microscopy, extensive infiltration of parenchyma by mononuclear inflammatory infiltrate containing small lymphocytes, plasma cells, and well-developed germinal centers. Thyroid follicles may be atrophied and lined by many areas of Hurthle or oxyphilic cells. Hurthle cells or oxyphil cells, they are nothing but they contain abundant eosinophilic granular cytoplasm due to metaplastic response characterized by numerous predominant or prominent mitochondria. Hurthle cells or they contain abundant eosinophilic granular cytoplasm because of the presence of numerous abundant mitochondria. The interstitial connective tissue is increased, and in fibrosing variant of Hashimoto's thyroiditis, the thyroid is small, atrophic, with extensive dense keloid-like fibrosis which does not extend beyond the capsule of the gland. In fibrosing variant of thyroid, it is small, atrophic, with dense keloid-like fibrosis which does not extend beyond the capsule of the gland. So this is the microscopy of the Hashimoto's thyroiditis. You can see the follicles, thyroid follicles are atrophied, and you can see the prominent germinal centers. There is dense lymphocytic infiltrate, and you can see Hurdle cells in between. They're nothing but they're also called as oxyphil cells. They're large cells with abundant eosinophilic cytoplasm. Clinical features of Hashimoto's thyroiditis, it is painless enlargement of the thyroid gland associated with hypothyroidism in a middle-aged woman, and it is always symmetric and diffuse. The enlargement is symmetric and diffuse. Patients often have other autoimmune diseases and are at risk of developing B cell or non-Hodgkin's lymphoma. The patient will have painless enlargement of thyroid and it is diffuse. Coming to the dequerent thyroiditis or subacute granulomatous thyroiditis, it is common in between age group 30 to 50 years. Women are more prone than men, caused by a viral infection or a post-viral inflammatory process. Majority have history of upper respiratory tract infections prior to thyroiditis. Morphologically, the gland is formed with intact capsule and unilaterally or bilaterally enlarged. Histologically, there is disruption of thyroid follicles with extravasation of colloid, leading to a polymorphonuclear infiltrate, which is replaced by lymphocytes, plasma cell, and macrophages. The extravagated colloid provokes a granulomatous reaction with multinucleate giant cells, some containing fragments of colloid. Hence, the name granulomatous thyroiditis is there. Healing occurs by resolution of inflammation and fibrosis. Thank you.